this patient stroke wasn't noticed for 2 hours. Now you've already lost 2 hours. Clock's ticking. So we proposed that we take out the provider and we empower the nurse. It has to be a nurse who is trained, obviously, through this education rollout that can activate a code stroke. And then the first responders that come to support that nurse and to validate their assessment and then to roll them to CT would be the rapid response team.
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Welcome back to the Rapid Response Run podcast. I'm excited today because we're talking about time-sensitive emergencies. We love like sepsis, STEMI, shock. They all have clear indicators. The blood pressure is low, there's ST segment changes, but inpatient strokes are often quieter, more subtle, with more subjective symptoms that are far more likely to be missed or overlooked. So today's episode is about what happens when nurses are empowered to act before we have a clear diagnosis and how that can make the difference between recovery and life-altering deficits. So I'm joined today by Kat. She's a fellow rapid response nurse who is passionate about nurses stepping up and driving change to improve patient outcomes. So Kat, welcome to the podcast.
Thank you for having me. It's an honor to be here.
Oh, I'm so glad to have you. So let's just start by, can you introduce yourself? Like, what's your credentials? What's your role with your rapid response team?
Yeah, sure. So my name is Kat Siaron. I am a rapid response nurse. I used to be a neuro ICU nurse prior to that. I work currently at Parkland Hospital in Dallas, Texas. But the research that I'm going to talk to you about was from my prior institution, UT Southwestern, right across the street, where I used to work as a neuro ICU nurse and then as a rapid response nurse. Currently, I am leading my team as an assistant manager of the rapid response team at Parkland, like I said. And yeah, super passionate about research, love stroke, that this is like my training. This is my bread and butter, and love learning from everybody. So hopefully I'll learn something from Sarah as well.
Okay, awesome. And then you don't just love this stuff, you also research it. What is the name of the article that you published?
So the official name is Rapid Assessment Teams, essentially shortened time to stroke discovery and treatment. When we were actually doing this study, though, our acronym for it was the RRT STAR study.
Ooh, I like acronyms.
Yes. I wanted to empower our fellow nurses to be like, no, you are the star of the show. You drive the show. Because, that's a little bit of a cognitive switch we have to do as nurses, where we are the one leading this program. So yeah, it was called the RRT STAR study. And we did it at UT Southwestern. We looked retrospectively at data over 6 years span time and kind of looked at the evolution of this new program. So it's almost like a pre and post comparison study where we're looking at data and timestamps from before we implemented this new process and then after.
Okay, awesome. So I wanted to point out why this is so important. I feel like ERs often have this like down packed. They have such a fine-tuned process for you show up in our ER with stroke-like symptoms. Oh, we have a path for you to go on. Yes. We have a team that shows up. It is so highly well orchestrated. Their door-to-needle times are often great because they've practiced this and practiced this.
Yep.
And there's a ton of them. Inpatient strokes are different.
More difficult.
Things are more vague. The process is a little more clunky. And it varies so much from institution to institution. So let's just talk about your research and the differences between inpatient strokes and ER presenting strokes through a case study.
Yes.
So you had shared a case study with me, but will you share it with my audience? Tell us about this patient.
Yes. So this happened in 2019. early 2019. I've obscured the details on purpose to protect the identity of this patient, HIPAA, of course. So this was a patient that was admitted to CVICU for an aortic repair and a CABG. They'd been waiting for this procedure for a while. They had a lot of comorbidities, so they're high risk, so COPD, hypertension, diabetes, smoking history.
Classic, yeah.
The recipe, right? So it was a classic CVICU patient. They went to surgery. The surgery itself went well, all things considered, but it was long. It was long. They had to do a lot, almost 11 hours in the OR.
Goodness gracious.
And the patient then went to CV after the surgery, had a little bit of hemodynamic instability overnight. So the physicians decided, snow him. Let's just keep him paralytic sedation overnight so that we can gently wake them up in the morning, prevent those BP spikes that would put the aortic repair in jeopardy.
Valid, yeah.
Of course. So they then weaned the paralytics in the morning very slowly, like I said, and then they waited for the patient and they waited for the patient and they waited and the patient wouldn't wake up. Unfortunately, they remained largely unresponsive even through shift change. The nurse was like doing their morning oral care, suctioning and a little coughing, over breathing the vent, but not waking up. And, suctioning somebody, especially after surgery, coughing is pretty painful. So you would expect they'd open their eyes. No, nothing. So the resident in the morning who assessed the patient was like, well, maybe it's just the sedation. We did snow him a lot. So the night shift nurse hands off to the day shift nurse. They talk about it. The day shift nurse says, are we not concerned about this? Because this patient's kidneys are okay. Their liver is okay. Their numbers are fine.
All right. They should be clearing the sedation.
They should be clearing it. Yeah. And, they looked at the Foley, like we've put out 2 liters overnight. It's not like we're not peeing. So, here we are. And so the CV team rounds at around 8:30, as they usually do. And then they tried to stimulate the patient. They tried to do their assessment. And it was during this time that they debated potential causes of the sleepiness beyond sedation. They're like, did we stroke this patient out? And most of the providers kind of wanted to write it off as sedation, but the attending agreed with the nurse and said, it's worth investigating. However, because at this time we didn't have a specific inpatient process for something that's a suspected stroke, instead of calling a code stroke, which inpatient we didn't have at the time in the ICUs, they ordered a stat CT of the head. You'd be like, well, that is what you do in a code stroke, right? There's a difference, though. So this nurse did her best to get this patient down to CT as fast as possible. But as you know, as the CVICU nurse, getting a fresh heart to CT is quite challenging. It is logistically challenging. It's like a dance. And so arriving in CT was like 45 minutes later, just with all the tubes, drains, etc. In the ventilator, you have to wait on RT to go with you, etc. And she's also not a neuro nurse, so she doesn't really know what to look for on that CT scan. But they do the CT scan, get it done. She looks at the image when she's passing by to leave, and she's nothing big or obvious. Then they return to ICU. And she doesn't think any more of it until an hour later when radiology is messaging her and calling her attending and saying, ringing the alarm bells, oh no, something's wrong. They saw a pretty big basilar ischemic stroke that was still developing. So for the people on the podcast who are not neuro nurses, it's the basilar area of the brain is the brainstem. And a stroke there is pretty bad because the brain has nowhere else to go when it swells. And it's also kind of the gatekeeper between the higher order brain functions and the rest of the body. So it's a very critical area. And whenever we see strokes there, it's definitely a red flag. So they immediately activated a code stroke then, after they'd already done the CT, right? But this was a little late. And having had recent significant chest surgery, right? This patient was ineligible for, at the time, it was still TPA, not TNK. So risk for bleeding, we can't give him TPA. The only option would have been what we would call an endovascular thrombectomy, where they go in through an IR procedure, try to get the clot, just like how they do for cath lab,
right.
Cardiac cath lab, except they extend the suction all the way up to the base of the brain to try to pull that clot out. But that kind of procedure, the EVT, has, at the time, a 24-hour window, which, by the way, is generous. Most institutions, smaller institutions, will do 6 to 8 hours after the onset of a stroke. Our institution went all the way up to 24. Unfortunately, because this patient was never woken post-op, that we are now past 24. It's now, 10:30 in the morning. So we're at almost 28 hours post-onset of stroke. And so they were considered out of the window. Now, our specialists, the neurospecialists, still looked at this patient and considered it. They went back down to do another CT scan, this time what we call a CT perfusion, just to try to see how the blood flow in the brain was doing after that. And unfortunately, the CT perfusion showed that the stroke had already started developing to the point where doing EVT would have probably resulted in, the risk was high for hemorrhagic conversion. And so we didn't want to add insult to injury, so to speak. So for this patient, all we had left to do was to try to manage the swelling and the deficits after that as best as we could, which is a very sad outcome, right? Because this patient's cardiac surgery was beautiful, went really well. And they had a good chance of going home with very little issues as far as the cardiac goes. But as we all know, any kind of cardiovascular procedure carries a huge risk also for the brain for strokes. And this was a very sad case. So that was the case study that we used to present to our leadership when we said, we need to probably have a better workflow whenever a nurse suspects something is off, or even it doesn't have to be a nurse. It could be another provider, a resident who suspects something is off. And we want to just go and call a cold stroke, get the specialists on board. It took a lot of work and a lot of conversations. But yes, this was the case study that informed the process.
Yes. So when I'm hearing the story, there are honestly, hindsight's 2020, right? So I'm like Monday morning quarterback in this case. But there's so many key places where intervention could have happened, where like things would have gone better for this patient. The other thing I want to point out is when we empower nurses to be the ones to call the stroke alert, often there's education that goes alongside with that rollout. And so nurses can like recognize that there's an issue earlier on because they've just been educated about this process. So I'm sure as a neuro ICU nurse, you heard this case and you're like, oh, we missed the opportunity. Like we could have saved the penumbra, but we took so long.
Yes, we could have saved the penumbra, indeed. And, I remember caring for this patient actually, because I was still in neuro ICU at the time in 2019. I wasn't in Rapid yet. And so when Rapid reviewed the case a couple of years later and said, this is one of those case studies, I was like, wait, I remember that patient. I took care of them as a neuro patient because now they're a CABG plus stroke, which is not great. We want to prevent this, right? That was the whole point. We want to prevent this. So yes, nurses empowered can save the penumbra.
Okay. I wanted to take a moment and just talk about basilar strokes, how you pronounce it.
Yep.
These to me are like some of the most heartbreaking.
Yes.
Can you talk about like the symptoms and long-term prognosis for someone with a basilar stroke?
Yes. So symptoms are pretty, unfortunately, significant. Somebody with a basilar stroke probably they may have difficulty swallowing or speaking, a lot of nausea, a lot of weakness. And it's not like the single-sided weakness that you would see on a higher stroke where it's a cortical stroke. They might have generalized weakness, dizziness. This is the mild version, mind you, visual disturbance.
I was going to say, this is not a bad version.
This is the mild version.
It gets much worse from here.
No, it gets worse. The big basilar strokes means they may not be able to wake up at all. They may not be able to open their eyes at all and interact very meaningfully with somebody outside of the locked-in syndrome, if you've ever heard of that, is the worst form of basilar stroke, I think, where you're entirely awake and conscious and you can hear everything going on around you. And all you can do is see through your eyes, but you can't move your mouth, you can't talk, you can't move your arms, you can't move your legs. So it's being trapped in a room, unable to do anything. Literally a horror story. It's straight out of Stephen King.
Definitely like my worst nightmare is I can be fully aware of what's happening and can't do anything about it or respond. Some of them can still blink.
Yes.
And so they can find ways to communicate with blinking, but that's...
Not everyone.
That sounds like torture. Yeah. Yeah, not everyone.
Not everyone. And some patients have described it to me. We can rehab this, sometimes the milder version. They say that it's like sleep paralysis, except it lasts forever. If you've ever had sleep paralysis, it doesn't end.
Oh my God. Okay. So you hear this case, you're like, we got to do something. All right. What was the process, the shift, the culture change, the education you did? What was the overhaul you did on the inpatient stroke alert system?
Yes. So first and foremost, before we could start educating and start rolling out anything, we had to have a workflow, obviously. We have to have a change in the proposed. And the workflow that we had, which is included in the paper that we published with the study, the workflow shifted the first activation from a physician or a provider to the nurse. So if you are the nurse at the bedside, whether it be in the ICU or the floor, anywhere in the hospital, you see signs of a stroke, you are empowered to say, I'm going to call a code stroke. You don't have to say, let me notify my provider. Let me wait for them to come. Let me wait for them to do their assessment. And then maybe if they agree with me, they'll activate a code stroke. No, we said, we're going to cut that time. That's a good 20, 30 minutes, maybe longer.
That neurons are dying. Yeah,
correct.
20, 30 minutes,
correct.
That neurons are dying.
Correct. And remember, so for EVT, the window is 24 hours. For T and K, which is the clot buster medication, you only have 4 hours. So if this patient stroke wasn't noticed for 2 hours, now you've already lost 2 hours, clock's ticking. So we proposed that we take out the provider and we empower the nurse. It has to be a nurse who is trained, obviously, through this education rollout that can activate a code stroke. And then the first responders that come to support that nurse and to validate their assessment and then to roll them to CT would be the rapid response team. So then the responsibility now of making sure that we meet all of the time benchmarks would be on the rapid response team. This also helps nurses on floors where they don't do this kind of rapid activation very often. I mean, it's not something you do every day. So you're like, wait, what do I need to bring to CT? I've never been to CT before. Where is CT again? On the second floor, third floor? So these are things that little process issues that we don't think about, that floor nurses and PCU nurses have to think about consciously. And it takes time. It takes time that we don't have. So we proposed this process. We made a whole flow chart, which you can find on the paper. Like I said, we made a whole flow chart, went to the leaders and we said, we have identified a gap. We gave them numbers for the past X many years. Here is your time benchmarks for inpatient strokes. Compare that to our amazing time benchmarks for ED strokes. What are we missing? And we said, we propose that nurses, and let me tell you, they were not excited about it at the beginning because, of course, they're like, well, you're not providers. And I said, yes, we're not providers. And we're not saying we are. We're not saying we're diagnosing the stroke, but we suspect that there is one, which is within our scope, right? And let's get the experts here to assess with us. It took a lot of pushing, a lot of conversations.
Of course.
We also proposed that this process include the ICUs because I said, yes, in neuro ICU, it seems redundant because these neuro ICU nurses, this is what they do every day. But in places where CV ICU, even if they know what a stroke symptom is, they know how to give TNK, all of that, or in MICU, those nurses need help transporting their patients anyhow, very quickly to CT. Having 3 nurses transport a patient who's intubated is much safer than just one nurse and one RT struggling down the elevator, And so I said, even in those ICU settings where you have a trained nurse, having extra resources never hurts this patient. And it's a life. We're saving functionality.
Right.
We're saving them from debility. So when we gave them the numbers, which is what they listened to, they said, oh, okay, all right, we do have a gap. And, I questioned all of your listeners on your podcast. What is the gap between your ED times versus inpatient times? Because that's not something that a lot of institutions look at.
Right. They report out the ER times, right?
Yes.
But the inpatient ones, we just don't talk about it.
Yeah, exactly. But we should.
And the thing is, they can be just as good.
Yes.
The times can be just as good if there's a good process in place.
Correct.
I wanted to echo back a couple of things that you said.
Yes.
Number one, you said that some nurses just aren't as experienced with the stroke patient. You're on the renal floor or the cardiac floor. So stroke is not their thing. But they'll be a little slower doing the NIH stroke scale versus maybe a rapid response nurse. They do this all the time. They can fly through it. So maybe infamiliarity with the stroke symptoms and processes. And rapid is what I do best, meaning I'm fast. Like when I show up to a room, I can get that patient out of that room in like less than 2 minutes. Unplug, only the essentials, clear the hallway. Like rapid is my thing.
Yes.
And so yes, a critical care nurse may be an expert in stroke and they can do the assessment. But when I show up, my role as the supporting rapid response nurse is get them moving rapidly.
Correct.
And that rapid transport allows for rapid diagnostics and then ultimately rapid intervention. And that's what I'm shooting for. So the speed that activating the team gives you is just as valuable as their expertise in the stroke. So yes.
Correct.
Even a critical care nurse who's amazing, it's going to take a minute to get the patient to CT.
Yeah.
Why not have a buddy come alongside you and talk about and get them out of there?
Exactly. I only have 2 hands, right? And, as ICU nurses, we all know how many devices we transport. You sometimes look at your wires and you're like, I only have 2 hands. What do I do? Having that help that you can trust can move quickly, but also safely is key. And this was something we had to also articulate to leadership because we told them it's not just about the diagnostic, and it's the logistics of moving a patient, critically ill patient. But yes, I have the results from our study, which actually, like you said, to echo back what you said, it can be just as good as ED times, if not better. Prior to this workflow, this nurse-driven workflow, we took about 23 minutes on average to get to CT. It doesn't sound bad. We are a comprehensive stroke center, so of course we should be good. But at the same time, you could be better. And then after the study, which, like I said, we implemented it in 2019, 2020, and we started seeing changes. Our average time to CT dropped to 15 minutes from discovery time. 15 minutes. So that's shaving off, 7 minutes or so, 8 minutes. It doesn't seem like a lot, but if you consider a patient who's almost out of the window for TNK, the 7 minutes matters. I don't know if you've ever given TNK and seen them recover their function like that.
Oh, it's wild.
It's wild. Yeah. It's a beautiful thing to see.
Gives me goosebumps to think about it.
Yes, it's beautiful to see. The most significant number that we saw, though, our N wasn't very big. It was just a few patients because, of course, EVT is not as common as giving TNK. But the most significant number that we saw on the intervention side was the time to thrombolytics and the time to EVT. So the time to EVT was halved. We went from taking almost 2 hours to get to EVT, 119 minutes. So that's like opening IR, getting all the people in-house, making sure the patient has consent forms, all of those things. We have the time down to 73 minutes. So significant change there. Only a few patients, but every single patient is a single life.
Absolutely.
And so I think the study bears repeating in other institutions. Every institution's logistics are a little bit different. But if one institution can show you that this process is possible and you have this much benefit, just by shifting the activation to the nurse, empowering those nurses to be able to ring the bell, if you can get this kind of benefit, why not?
Yeah, agreed. So thinking back, when you presented your idea to admin or to the people that had to approve it, the powers that be. What were their pushbacks, concerns?
Yes.
Hold up?
Yes.
And then how did those end up working out in the end? How did you kind of prove them wrong?
Yes. So the biggest significant holdback was, of course, the scope of practice. They were always like, wait a second, this is usually a provider call. And we said, we're not diagnosing a stroke. We can't, right? We don't have an imaging. We don't have a neurologist. But I said, if we call a code stroke and the code stroke involves the neurologist showing up, then actually what we're doing is not stepping in front of the provider, but empowering them to know, hey, this is a patient you should be anticipating, you should be looking at. And so we added the neurologist in this code stroke process where, just like in the ED, when a code stroke rolls in, the ED tells them, hey, stroke incoming in 5 minutes, they show up at the bay. This is the exact same process where the neurologist shows up with a rapid response team and follows them to CT and does their assessment as they're moving to CT. So we said, we're not taking away from the provider. We are actually making their job better.
Yeah, we're expediting for them.
Yes, we're expediting them. They're going to get the images because you know how they are. They're like, where's my imaging? Where's my imaging? Here we are. We're doing it for you. But at the same time, those neurologists can then have a face-to-face with the actual ICU team or whichever primary team is taking care of this patient instead of just showing up to a room with no report, no handoff. So that's one thing. And they were happy once we said, no, the neurologist will be with us. We're not going to make the call unilaterally as nurses. It's a team effort. The other big roadblock that they were worried about is, well, this is a really big hospital with lots of units and different specialties. How are you going to be confident that a floor nurse can call for a code stroke correctly? And I said, that's why you have the rapid team. Because when the rapid response nurse shows up, which our average response time is about 2 minutes, you can have that second critical care trained, stroke certified, NIH trained nurse to be at the front line and support this other nurse who may not be as familiar with stroke, and they can then talk two brains together looking at the same patient.
Right. Did we get a blood sugar? How long has this been going on? Like, let's do a little further detail just to make sure this is worth traveling to CT for. Right.
Just to make sure. Right. And then also knowing that, don't worry, if both of us are looking at it and it's confusing or concerning, neurologist is right behind us. They're coming in 5-10 minutes. And usually our neurologists were at the bedside within 5 to 10 minutes. So it was that essentially a safety blanket, I said, for the floor. That's how I describe it. It's a safety blanket for our nurses on the floors who, like you said, very big hospital, different specialties. They're looking at something they think is a stroke, but they haven't seen one since nursing school or since, the textbooks. And they want to do right by their patient, but they just need a little bit of help to make sure. So this was that safety blanket to allow them to call the experts quickly. And if it's nothing, then no big deal. That means that we get to, okay, cool, walk away. And it's 10 minutes of my time, no problem.
Yeah.
I mean, what's so wrong about helping our fellow nurses on the floor expedite their care? So those were the two biggest pushbacks that we got from admin. Once we kind of got them their numbers, though, they said, okay, we're willing to try it. The rollout of the education was, I will say, challenging, right? Because now you're telling a whole institution, remember, be fast. And all of the floor nurses who, for example, maybe they do oncology or something, or like L&D, for example, which was always always a trip because they're like, brain what? Because they take care of healthy moms who are coming in to give birth. But when we started talking to them about BFAST, we said, remember, your pregnant moms are actually at risk for a stroke. They're at pretty high risk.
They're hypercoagulable. Yeah.
Correct. Pregnancy is a very risky state. And if you have, a mom who has a stroke, it's a very complicated case. So you should know how to call for help. Education was a team effort. And also we worked with the education departments. We worked with the hiring departments because we wanted to hit them as they came into the hospital. Here's our culture at this hospital. You call the rapid team, you call a code stroke when you see stroke symptoms. They're like, oh, we don't wait for a provider. No. In this hospital, you are the nurse. You are the eyes on the patient.
Love that. So I just want to add to what you're saying. My hospital has a similar process.
Yeah.
And so just to keep it going, to keep it alive in fresh people's minds, yes, people have badge buddies that tell them when to call a stroke and like what to look for, what to assess, what to know when the team shows up. Yes. The rapid responders are all trained. Yes. But as far as all the new hires, every new hire at orientation gets a spiel from the stroke coordinator about stroke-like symptoms, what to do, how the nurse is empowered to call a stroke alert. Here's who shows up. Here's what to expect. They hear it from the beginning. And then we also do this thing. They get like stroke pins. So for nurses that call stroke alerts and it was a stroke and the patient got intervention because of their speaking up and advocating, our stroke coordinator does like a whole deal. Like they go to shift huddle. They like present the nurse with like a brain pin that goes on their badge. And so there's nurses walking around the hospital that have a great story to tell about the time they saved a life because they recognized stroke-like symptoms and activated the stroke team.
I love this.
And then we post it like on the Facebook page for our hospital employee group. And so you get to hear all these stories of lives that were saved, patients' outcomes that were improved. And then nurses have these pens that say like, yeah, I was a part of saving this patient's brain. So it really just reinforces the culture that this is a nurse-driven process.
Yes.
We want you to speak up, call early, call often. Don't be afraid of us be like, this isn't a stroke. Why would you call us? Instead, we just show up and say, thanks so much for letting us know. This seems more metabolic or because of X, Y, and Z, we're probably going to not do this. Whatever. It's okay to call and be not a stroke.
Yep.
What's not okay is to be like, oh, I hate to bother them.
Yes, exactly.
And then the patient's neurons are dying and we're like losing penumbra. And
we're losing time. And you, as a rapid responder, also when you set your eyes on that patient, if it's not a stroke, now you can diagnose what it is because something is wrong. Right.
Something's
and stroke, there's a lot of stroke mimics. Sepsis is one of them.
Yep.
Toxic metabolic encephalopathy, like you said, is another one of them. A bunch of other issues could be happening, or it could be something as simple as, the other day, I took care of a patient who went downstairs and smoked. And they smoked a substance. And they came back up and they were not quite talking the same way. So the nurse was like, slurred speech. But that's okay. Now we know what was the cause. I was able to help them, educate and also reinforce this is not something we do while you're hospitalized.
Right.
But it's important also for whatever else could be going on.
For sure.
Because we also want to treat those things.
Even if we did 9 CTs on people not having a stroke, but one of them caught a stroke.
It's worth it.
Worth it every time. I'll run across the hospital pushing beds to save that one person gladly, right?
Gladly.
So I'm all for the nurse-led intervention when it comes to time-sensitive condition. Very good.
And that is one thing we do have to remember too, as nurses doing research, when we get caught up in all of the P number, the P value and the N's and all of these, whenever the leadership said, well, your number of patients is really small, I brought them back to that N of 4 is 4 people, 4 real people whose times we improved. So even if it's a small number, I agree. It's worth it.
Agreed. Okay, so let's wrap it all up.
Yep.
What would you say are the key takeaways for bedside nurses, namely on inpatient units? Because ER is different. They call you in the ER and say, I have stroke-like symptoms. They show up in triage and their complaint is stroke-like symptoms. Often in inpatient, the patient has no complaint. It's the nurse that recognizes it.
Correct.
So what would you say are the takeaways for the bedside nurse to know? And then if you are someone who has the power to make shifts in hospital processes, what do you want them to know from this talk today?
Absolutely. So for the bedside nurse, the biggest thing is to know your BFAST. We have that acronym for a reason. It's easy to remember. And it does focus on those big, what we call hemispheric strokes. It catches the big strokes that really do carry the most functional damage for the patient over time and has the higher likelihood of disabling this patient over time. And don't doubt your assessment. Trust your gut. Because that's the thing a lot with experience gives you this kind of spidey sense, I like to call it. But what it is pattern recognition. You've seen this kind of patient over and over again, and something with this one is not fitting your pattern. So when you feel like something is wrong, go ahead and call for help. Don't delay. And if you end up, like we said, being it's nothing, then all the good for the patient.
Great. We've ruled that out. Perfect.
Yep.
What is it? What is it then?
Exactly. So know your BFAST and also be aware of your patient's history, because some patients are at higher risk for stroke than others. An example of this would be a patient who, maybe if you have a young lady who's admitted for something else, if they're on birth control, that's one of those risk factors that we don't think about, but it is a high risk factor. So just know your patient and trust your gut would be the two things I would say.
Love it.
And very simple advice that I think all of us can follow. And then the second part for anybody who has the power to change processes in their hospital or who is in a position to effect this kind of change, the biggest lesson I learned from this is two things. One is numbers are everything. If you can show with data that there is a gap, right? That's where you actually start having that conversation. And don't wait until you have I have a great idea with a proposal with a flow chart that's all pretty and beautiful. No, start talking to people just when you start finding that gap. What do you think about this problem? Or have you seen this happen in your unit? Talk to other managers, talk to other educators, and see if it's something that's isolated in your department or others. Because the more allies you have, the more friends you have in different places.
Meet the numbers, baby. Yeah.
The easier it is to do. And this is a big project. Took 2 years to finish, right? Mm-hmm. And so the more friends you have to help you do this, because obviously you also want to have a day off, the better the process will be. And they can give you ideas too that you may not have considered, or tell you maybe that's not going to work for my department. We may need to tweak it like this because of our workflow. You don't know that if you're not in their department, right? The second thing that I would say is persistent conversation is key. Do not let yourself get shut down by one person saying, no, I don't like this. One person is not the whole institution. You may find allies elsewhere. And also, maybe that day they just weren't willing to entertain an idea, but you can kind of reterm the idea, like say it in a different way and convince them. So persistence is key, especially with big projects like this that require a lot of time. And for the institution, they're thinking of resources, right? They're thinking, can we afford to divert resources to this project versus others? There are other projects that could be done. Persistence is key. You don't give up when one person shuts you down. You have to keep pushing. And ultimately, at the end of the day, keep in mind there's that one patient who will benefit from it.
Yeah, for sure. Okay, so to wrap it all up, let's go back to your case.
Yes.
Let's say the same case happened.
Yes.
Today at your hospital.
Absolutely.
The nurse recognizes this patient's just not waking up, but they have a good cough, they have a good gag.
Yep.
But they're not waking up.
They're not waking up.
What would they do now? And how would this have gone down differently?
Yep. They assess. They suspect. They're like, They go to the phone to page the rapid response team or to the computer to page the rapid response team. Rapid response team shows up in 2 or 3 minutes and they do their assessment. They do the same thing, quick 5-minute, very expedited one. And then they roll. We have, with the rapid response order set, they have a CT scan, a blood glucose order, and notify the provider. The neurology gets paged automatically with this. And CT scan gets notified also so that they're ready to receive us. And there's no more, hold on, I have a patient on the table. They'll open another CT scanner for us if they need to.
Okay.
So this order set gets put in and we roll down to CT. Like I said, average 10 to 15 minutes. We're there down to CT and we do the CT scan. Usually the neurologist finds us in the hallway as we're going or downstairs in CT scan. They'll meet us down in the scanner. And the neurologist then, as we're scanning the patient, gets the story from the primary nurse, gets the story from us. The primary nurse obviously goes with us. And then as soon as the CT scan is done, the neurologist can see it right there. They can assess it. And then they can make a decision based on their clinical assessment of the patient still on the CT table. And on the CT scan that they see, the image that they see, okay, do I want additional imaging for their vessel, CTA? Do I want a CT perfusion? We're already in the scanner, so we can get all of the imaging done immediately. They can have all of the images they need to make a good decision, informed decision for this patient's care. And if we need to, the pharmacist also responds to this code stroke. So if we need to give TNK right there in the CT scanner and the doctor says that's a big, large vessel occlusion, an LVO, we need to give TNK now. Me as a rapid response critical care, I can draw up that TNK and I can give it myself. Right? So we can give that TNK in the CT table. We don't even have to wait for a bed. We don't have to wait for an ICU bed. We don't have to wait for pharmacy to mix it up. We have it right there. So that really cuts down to intervention time as far as the thrombolytic. If this patient, for example, the surgery patient, because they're not qualified for TNK, cannot get TNK and they need to do EVT, then what we can do, finish all the imaging, we take them back to their bed where they are as IR is getting ready and opening the suite. Because the neurologist can activate it right there from the CT scanner. Say, hey, I need the interventional radiologist. We're going to do an EVT on this patient. And then that way they can start working on the consent. We stay with the patient because now they're classified as a critical care patient. So Rapid stays with the patient to then deliver them to IR as soon as IR is ready. And usually it's within less than an hour.
Wow.
So then that way we can get this patient taken care of in a timely manner. And also that primary nurse who, poor thing is suddenly taking care of a critical care patient isn't alone with this emergency.
Right.
And so it also helps our fellow nurses.
Yeah. Good for culture.
It's good for culture.
For sure. So back to this case, if this process was in place back then when this happened, the nurse could have called the stroke alert. Another nurse would have showed up to expedite the trip to CT. So 45 minutes to get to CT would have been like 5 minutes, maybe 10, but probably 5. And then we could have got the diagnosis earlier on. They're not a candidate for TNK, but they could have gone to thrombectomy possibly and maybe not been locked in for the rest of their life.
Yeah, we could have slid them right into that 24-hour window because remember, the night shift nurse already started suspecting it. They could have called it. They could have called it themselves without waiting on. And yes, another culture shift that has to happen, like I said, is that cognitive switch of, is it okay for me to call this without my provider knowing? Some nurses get really scared of that. I'm stepping on the provider's toes. But the key to that, addressing that is always conversation. Like, hey, I was just really concerned. It wasn't meant to go over you, but this is the process in this hospital. And that is the benefit of having a process too, is when a doctor questions you, why the heck did you call a code stroke? You say, well, in this hospital, this is what we do. And then that floor nurse or ICU nurse can then refer to the process and show them the purpose of this is to expedite the process and not to step over your toes. I think most providers are actually very receptive of it in my experience. They like it because it's fast. They like fast things.
Results quickly. Yes, that's what they want.
Yes.
Kat, this is such a great case to highlight the value of nurse-driven protocols.
Yes.
This case is a reminder that nurses are often the first to sense when something's wrong, even before there's proof, right?
Yes.
And systems should be built to support that instinct and not slow it down.
Yes.
So thank you, Kat, for taking the time to shift that process at your hospital and to set up a system that supports the nurse and ultimately the patient.
The patient.
So thank you for showing in here today.
I really appreciate it.
Anything else you want to leave people with before I let you go?
Trust your gut.
Yes. Amen. All right, Kat. Thank you so much. Have a great weekend.
You too. Thank you, Sarah.